I put the SLT in my office 11 years ago, and I've done between 4,000 and 5,000 eyes in probably half that number of patients. I use it as primary therapy, and most patients, when it's explained correctly, do opt for SLT instead of drops. And the benefits are fairly obvious. The expense and bother of eye drops and the local and systemic side effects of the eye drops are not anything that patients look forward to. And with an SLT, when it works, and that's a definite majority, then they get pressure control without the bother, the expense, and the side effects. And as adjunctive therapy, some people need lower pressures than we can get with drops and lower pressures than we can get with SLT alone, and that's when we do both. Well, the benefits to the patients, besides less cost and less bother, are that, eye drops, there's a tremendous and partially unknowable problem with compliance. With SLT, when it works 24/7, and there's no issues of compliance, and they've got the control they need to save their nerve. The benefits of SLT over medications are primarily the convenience, lack of expense, lack of side effects, and lack of that big unknowable issue with compliance with the medications. Yes, when I first got the laser, I was told to do subthreshold treatment on a 180 on half the angle. And I did that, and I would turn it up until I had champagne bubbles, and then I would turn it down until I had no bubbles or almost no bubbles. There were patients whose pressures responded to that light treatment, but the responses were disappointing, to say the least. And so I started sneaking the 180 up to 220 and started turning the power up to where it was super threshold treatment, and the results kept getting better. And I discussed this with Mark Latina, and he agreed at the time. This was 2004 at the ASCRS meeting. He says, I think we've been under-treating patients for years. And if you talk to experienced users, the majority of people are doing 360s, and they're definitely doing super threshold treatment to where they see champagne bubbles on every shot or nearly every shot. And the results were dramatically better when I hit it hard enough. Well, it should go without saying, but you have to hit the trabeculum meshwork. And it is a very big spot size. You're sort of painting the angle, and if you hit a structure that you didn't intend to hit, it doesn't leave any damage behind. So in a sense, it's a forgiving laser, but some people have unusual angles, some people have variable pigment and skip areas where there is no pigment. And you have to keep oriented, and you have to avoid treating a pigmented Schwalbe's line or in a very lightly pigmented angle. Sometimes the only brown thing back there is the ciliary body band, and that's not where you want to treat. So you have to treat the trabeculum meshwork. I overlap spots. I use enough spots to where I've treated the angle, and I do not worry about retreating. If the patient moves and I lose my place, I go back a little bit. I overlap shots a bit, so I'm doing about 200 shots in the angle. And I started a power of about 1, but I pay almost no attention to the numbers. I look at the response. I start in the inferior angle. Most patients have pigment there, and I get a power that is giving me champagne bubbles. And as I go around and I come to lightly pigmented areas, I will turn the power up. And as I come to another area with good trabecular pigment, I will turn it back if I'm getting a robust response. And so I paint the whole thing. I use enough power to be confident that I'm doing something, and the results have been dramatic. I mean, in patients never on medication, 20% is a reduction in pressure is a success and 19 is a failure. You have to have a cutoff somewhere. And using that criteria, people on no meds or one med, 75% of them will have at least a 20% reduction in pressure with this protocol. Average reduction was 34% in my first 1,000 patients. And another unusual group is the people that I could not see the angle well just because of convex peripheral iris or something like that. I would do an iridotomy first and then treat them later. And we analyzed them as a separate group, and their mean pressure reduction was not 34%, it was 44%. So during the iridotomy and adding a properly done SLT, that was the group whose pressures went down the most. I absolutely feel it's the standard of care in this country, and when you consider the number of people in the world who have glaucoma who are not going to have access to ongoing drops, and the ease and speed with which this can be done in an amazing variety of settings, I see this being deployed across the world as the ideal first treatment for glaucoma, and that will allow a lot of people to be treated that there's actually no way that they can be treated with drops.